I'm Ellen McKenzie. I'm the Dean of the Johns Hopkins Bloomberg School of Public Health, and I want to welcome you all to this session and to a very vital discussion that we're going to have on confronting the legacy of slavery for health equity in Baltimore and across the United States. In 1619, 400 years ago, Africans first arrived in the U.S. colonies. Reports are that for the first group came as indentured servants. By the 1660s, race-based chattel slavery was the norm throughout the colonies. And after the Civil War, slavery evolved into a new set of discriminatory institutions that represented structural racism, with further devastating impacts on wealth, health, and opportunity for African Americans. Profound injustice, racial inequalities, and poor health. These legacies undermine the ideals of our new nation, and they continue to tarnish our country to this very day. Now today we are opening up a discussion on the relevance of slavery, not just to our history, but very importantly to the present. Our first panel will explore the legacy of slavery for health in the United States, and the second panel will explore its importance in Baltimore and right here at Johns Hopkins. We will hear from distinguished historians, scholars in health equity, and community leaders. I fully expect and truly hope that this discussion will continue not only in the reception afterwards, but in future sessions throughout the school, multiple avenues, both here in the school as well as beyond. And our purpose is not only to learn, but to act. I'd like to thank the primary organizers of today's event, and they include Bloomberg Distinguished Professor Lisa Cooper, who is jointly appointed in the Schools of Public Health, Nursing, and Medicine, and is director of our Center for Health Equity. And also to Jeremy Green, who is the William H. Welch Professor of Medicine and History of Medicine, and the director of the Institute of the History of Medicine. The event is also co-sponsored by SOURCE and the Urban Health Institute. So I'd like to end, before I introduce Dr. Green, I'd like to quote a recent editorial in the American Journal of Public Health by Drs. Tom Leviste, Mindy Foley-Love, and Robert Foley-Love, who called on schools of public health to hold sessions like this one throughout this year of 2019. And they wrote, "As a nation, and especially as public health practitioners, we cannot accept inequities as an inevitable element of the human condition. Importantly, 2019 represents a unique moment in U.S. history to reflect on the lessons of the past, and importantly, to commit to envisioning the next period in the nation's evolution free of inequality burdens forged in past years." So with that, I would again thank you all for being here and participating in today's important discussion. And it is my pleasure to ask Dr. Green to introduce our first panel. Dr. Green?
Thank you so much for that introduction, and thanks to all of you for being here today for this important conversation about the intersection of history and public health and its import for how we navigate the present and the near future. And it's really a great honor for me to introduce this panel. This is a wonderful array of scholars in the history of medicine and public health. And I want to begin by introducing the panelists, and then to also I have some questions myself to get a conversation going, but I want to invite all of you to, there are index cards that should be finding their way to your seats. And please, if there are questions that you have right off the bat, if there are questions that come up for you as the conversation develops, please write them down and they will find their way to me. And so that at a certain point in today's proceeding, I want the questions to stop being mine and have them come from you, because I know that there's a lot of interest in this conversation on many sides. So I want to begin by introducing the panelists alphabetically. Jessica Marie Johnson is assistant professor in the Department of History at Johns Hopkins University and studies the history of Atlantic slavery and the history of the African American diaspora. She is the author of Wicked Flesh, Black Women, Intimacy, and Freedom in the Atlantic World, which will be published this August, right, by the University of Pennsylvania Press, and is published widely in scholarly and popular venues, including Slavery and Abolition, American Quarterly, Somatosphere, Black Perspectives, and Bitch Magazine. Dr. Johnson received her PhD from the University of Maryland, has received a number of prestigious fellowships and awards for her research, including the Woodrow Wilson Foundation, the Gilder Leman Institute, and the Mellon Foundation, and she is a co-organizer of the Queering Slavery Working Group, the Latinegras Project, and the Center for Solutions to Online Violence. Elizabeth O'Brien is assistant professor in the Department of History of Medicine at the Johns Hopkins University School of Medicine across the street, and studies the intersection of surgery, obstetric violence, abortion, and reproduction in the Americas, it's an important plural, from the 18th to the 20th centuries. Her first book project, Intimate Interventions, The Cultural Politics of Reproductive Surgery in Mexico, 1719 to 1940, examines the intersection of science, medicine, theology, and gender in the experiential history of reproductive interventions. Dr. O'Brien received her PhD in history from the University of Texas at Austin, and her research has been supported by the American Council of Learned Societies, the Andrew Mellon Foundation, and the National Science Foundation, and the Fulbright Program. Deirdre Cooper Owens is the Charles and Linda Wilson Professor in History of Medicine and the Director of Humanities and Medicine at the University of Nebraska-Lincoln, and studies the intersection of health, illness, medical research, and the African American body. Her first book, Medical Bondage, Race, Gender, and the Origins of American Gynecology, published by University of Georgia Press, was based on her dissertation from the University of California, Los Angeles, and won the 2018 Darlene Clark Hines Book Award from the Organization of American Historians. She was also a co-recipient of the 2019 James Robinson Prize from the American Historical Association for her contribution to understanding and teaching American slavery. Dr. Cooper Owens is also director of the program in African American history at the Library Company of Philadelphia, and is working on a second book on the history of mental illness during slavery, as well as a popular biography of Harriet Tubman, which examines her life through the lens of disability. And finally, Alexandra White is the Assistant Professor of Sociology and History of Medicine, jointly appointed between the Krieger School of Arts and Sciences and the School of Medicine here at Johns Hopkins. He studies the social effects of infectious disease outbreaks in historical and contemporary settings, as well as the mechanisms that produce our response to these outbreaks. And his first book, Epidemic Colonialism, A Social History of International Disease Response, explores how and why certain epidemic outbreaks draw internationally coordinated responses and others do not, and how these differences are rooted in colonial and post-colonial legacies, including slavery and structural racism. He earned his PhD in sociology from Boston University and received the 2018 Elise Boulding Award from the American Sociological Association. And I should add, especially for this audience, we'll be teaching a new course this spring in the School of Public Health on the social history of epidemic disease management. And today's panel starts off our discussion by grappling with the embodied health legacies of slavery and what it means to take a look of the many different cuts that we have been having, as I hope, a national conversation about the 400 years legacy since 1619, what it means to take a public health perspective and to understand how the disparities that were etched into American society through the peculiar institution of slavery continue to resound within the bodies and within bodily forms of difference and disparity and in this field of public health. And so, since we're talking about a complex epidemiology of health disparities that has affected African American bodies and inflected the African American experience since 1619, it's worth taking a moment, since we sit here today in Summer Hall in the Johns Hopkins Bloomberg School of Public Health, which created the world's first Department of Epidemiology, to ask what it means to think of a deep history in relation to epidemiology. Epidemiology is a historical science, although most of our databases in epidemiology go back 5, 10, 20, 50 years. It's hard to wrap our heads around 400 years of historically inflected epidemiologic changes. And what I'd like to ask the panel to do first, and I know all of you have much to add to this conversation, is to give us a big picture chronology of how to think about the intersection of slavery and health since 1619.
Good afternoon, everyone.
All right.
Thank you, Jeremy, for having us and for having this really important conversation. I'm a historian of slavery, and so one of the things, I just want to say a few remarks about some of the historical context and some of the ways that I think thinking about the history and the way some of this shows up in the archive might be really interesting for this conversation. In this, I'm informed by scholars of slavery who are at the intersection of health and bodies and Atlantic African diaspora, Atlantic slavery, people like Jennifer Morgan, Marisa Fuentes, Sasha Turner, people who are working on reproduction. And I'm always reminded that sort of the heart of bondage became part of sequitur ventrum, which is slavery follows the womb. So there are a lot of ways that thinking about the body and thinking about reproduction and health are really critical to how we confront the legacy of slavery, slavery in its historical moment and legacy of slavery today. And when thinking about 1619, it's important to remember for me that these are conversations and tensions that were generated almost 2 centuries earlier than 1619. So if we think of in 1446 as the year that the Portuguese first landed on the coast of what is now present-day Senegal, sort of commonly understood to be Senegambia. And so the first slave trading from these West African coasts actually is back and forth between Europe and West Africa. And so this is a long story. Thank you. In that moment, we're talking less sort of about race and what becomes biological understandings of race in the 19th century. We're talking about questions of blood and bodies. We're talking about questions of divine rights of kings and God, and that's in some ways the positioning that different peoples are being placed into. And this is a conversation even as that slave trade moves across the Atlantic. The first slave trading and or Africans are landing and moving between Spain and the Caribbean in 1502 or 1510, depending on where you decide to make the historiographical argument. And so as early as that, there is the question as far as Spain and Portugal and as far as European empires of what to do with Africans that they want to enslave, how to create a logic and a discourse around that. Jennifer Morgan has talked about the ways that seeing Africans, particularly African women, as deviant, images of them circulating as early as the 16th century, 17th century, of them suckling over their shoulder, that this was seen as untoward, that this meant that they were marked for agricultural labor and could therefore be enslaved. So this is where some of these discourses are coming from and are very much figured on the labor that African women are doing on the continent, but also sort of images and representations of that are circulating in Europe. And another thing to point to are the kind of real economic parameters of this. And I won't talk long at all. So if we think of the piezas de las Indias. This becomes the currency of the Atlantic world. It's a measure of potential labor. It is, by the 18th century, it's being described like this, and this is a quote: "A male slave between 8 and 30 years old, with all of his digits and limbs, as well as eyes, ears, and teeth, was not hunchbacked or lame." And it meant that if there were difference in these, so if there were differences in age, in gender, in their faculties, in their what we call their ability or disability, that would be terms of further negotiation on the coast. So in this manner, 2 children might become a full pièce d'Inde or pieza de las Indias. A female adult might be maybe 3/4, depending on her reproductive potential or her size. And so these are the ways, like there actually is a kind of economic reality to breaking up bodies of the enslaved in this time period. And it's important to kind of think about how that then reverberates into the present day and how we look at Black people and their health outcomes, how they were treated by doctors, how the science sort of gravitates around them. And I'll end with this final note, that this legacy kind of reverberates even further well into something like the 20th century if we don't think critically about slavery. So as late, in case everybody doesn't know, the New York burial ground, now the New York burial ground, as late as 1992, there really wasn't anything sort of unscientific about sort of viewing a set of bones that had been uncovered, for example, in a burial ground, and determining mainly from their shape and texture whether these were the bones of Black people. So the forensic study of bones was used to determine skin color or race, whether somebody was impoverished or whether they were privileged, essentially sort of marking them in a lot of ways that DNA is sort of purported to mark their social and economic reality. And it was in the moment that New York burial ground was happening, once that, there's a lot of, and I can fill that in and the details of how this happened, but once the excavation of burial ground actually moved to Howard University and to the archaeologists and anthropologists there, then a different kind of rubric began to be used, a rubric that looked at the history of Africans in the Americas, that looked at the Sankofa symbols that are on the coffins, that looked at beads as residue of rituals, religious and otherwise. And so there are ways that, we, even into the 90s, have been strapped by how the pieza on, or piezas de las Indias, structured our view and our science around Black bodies, and that now we have an opportunity to kind of reflect and break out of those boxes.
All right, thank you. I echo Jessica's thanks to Lisa Cooper and Jeremy Green for organizing this panel, this symposium, and also to all of you for coming out. I really appreciate it. I'm Deirdre Cooper Owens, and although I came a long way from Lincoln, Nebraska, I got a little something to say. So, all right. So to think about Jeremy's question about the intersection of slavery and health, and in particular public health, it really makes me go back to, because we're kind of tag teaming, right? So Jessica gave you the Atlantic world perspective. I kind of do the unsexy history, as people call it. I do old school plantation slavery, right? But I try to have a conversation between the past and the present so that we understand that there is a legacy, unfortunately built on medical racism. And so where that starts for me is looking at the US Constitution, that document that does not include the word slavery, and yet slavery is all up and through it, if you would allow me just to get a little Southern for you. So it's up and through it because in 1807, the United States, a very new nation, decides, according to the Constitution, to ban the import of African slaves to what is the United States of America. And all of a sudden, you now have a concerted effort by the state, but also by slave owners and those physicians, some of whom are slave owners as well, right? They are now concerned with how to increase the natural rate of birth for Black women, because the condition of the child follows that of the mother, right? That was a colonial law that then becomes institutionalized by the 19th century. And so with this interest in protecting and preserving the fecundity or the reproductive health of enslaved women, you now have all kinds of articles and research and ideas and theories about how to make sure Black women live to have birth, right, to actually give birth, and that their children live past the age of 1. And so it depends upon which slave farm or slave plantation you're talking about. There were some people who would gift a mother, some slave owners who would gift mothers blankets or extra rations of food, or perhaps build a cabin, out in the back for that for that mother and her children, right? Because natural increase was the thing that could keep the engine of slavery running in the United States, right? And if we go back hundreds of years to British colonial America, we know by now that there were less imported Africans into what becomes the United States than any other place in the Americas, right? A little less than 500,000. And outside of Brazil, by the 19th century, the United States has a disproportionately larger number of people of African descent because of natural increase. And so what happens is the United States begins to pioneer gynecology. It doesn't invent it, right? But it begins to pioneer in this relatively new medical branch where white medical men are now concerned with knowledge production, technological advancement, and they're finding this out through the bodies of enslaved women. And I have said this in a lot of the talks that I give, and I don't say this to be a provocateur, or I don't believe in using hyperbole, but it can literally be traced that there was a concerted effort and drive in trying to make sure that enslaved women had relatively healthy births, right? Rather than when they were freed in 1865. Because all of a sudden, Black birth, right? Black birthing people, Black women who are giving birth were seen as financial burdens after 1865, whereas they were seen as a national asset prior to 1865. And so we then have to think about, what does the public health legacy look like for people who literally, between freedom and slavery, right, the medical establishment changes its views. And so those patients are not believed. There are these reigning scientific and medical ideologies or set of beliefs that state Black women know how to manage pain better if they feel it at all, particularly during childbirth. And so now what those numbers look like in terms of the present day, there is a crisis, literally a crisis, where Black women have a higher maternal morbidity rate and infant mortality rate and low weight births, right, than any other group in the country. And so for me, the legacy is, how do we have a concerted effort by every person in here, right, and every person in this country to eradicate those stats? Because the stats have literally been unchanging from century to century.
Thank you, Dr. Green and Dr. Cooper. Thank you, Jessica and Deirdre. I'm happy to be part of this conversation today and very much thinking about what Dr. Cooper Owens has just said about what happened, the investments that people who were invested in the institutions of slavery before 1865 and after. I'd like to take us through to the 20th century, through the mid-20th century, in order to ask questions about, in the 20th century, what were this nation's priorities in terms of providing health care for people, and how did those change historically? And so I'd like to get at the question of health disparities and health inequities moving towards the present, and to suggest that the answer about persisting inequities about those has everything to do with the legacies of enslavement as well. And that the current racial inequalities in healthcare are also due to the erasure of the intellectual and medical labor of Black medical health professionals. So first of all, I'll start with just a little bit of historical background, which is that in the early 20th century, the insurance industry was explicitly racially segregated, as were hospitals. Following Reconstruction, former slave states had enormous congressional power, as we know, and they enacted Black codes and Jim Crow laws in order to preserve the nation's racial stratification, including excluding farm and domestic laborers from New Deal policies, including the Social Security and Wagner Acts of 1935 and the Fair Labor Standards Act of 1938. And that same voting bloc on the state level made it a priority to control programs such as aid to dependent children, which then had the effect of effectively excluding Black people from healthcare systems. So even when in 1945, President Truman and Congress expanded the nation's hospital system, the states still controlled the disbursement of funds, and the segregation of healthcare institutions persisted. Meanwhile, the American Medical Association and other professional associations barred Black doctors, medical schools excluded Black students, and hospitals and clinics continued to segregate patients. And so in this moment of the consolidation of a national system of federal health care in this nation, implicitly and explicitly excluded Black Americans. And this was when really we started to see statistically a strong showing of this result of people whose ancestors had suffered under slavery having shorter and sicker lives than their white counterparts. Meanwhile, employer-based insurance was inherently difficult for those people to get. And so what I want to mention as well was that Black communities in this time created their own health systems. So Black women began to develop national community health movement, and a lot of different programs to speak to these disparities. And Black nurses and doctors established their own professional organizations and began a war against medical apartheid. So what happened with that war with the civil rights movement of the 1960s? Whereas the National Medical Association, which was the leading Black medical society, started to endorse strongly a slogan which had to do with healthcare as a basic human right. On the other hand, the American Medical Association became strongly opposed to a nationalized health plan, which they believed was un-American, and they were concerned about government intervention in the doctor-patient relationship. And so as a result, by the 1964 Civil Rights Act, which outlawed segregation, and as a result, the federally funded hospitals, the practice of segregation in federally funded hospitals, this is when we see the passage of Medicare and Medicaid, but these were still acts that excluded millions of Americans, if not by virtue of their access to it, also by age, employment, and income groups, and so that resulted in many people still having little to no access to health care.
I want to echo the notes of thanks to Jeremy and Dr. Cooper, and this is a really terrific moment to reflect on a lot of these questions. I want to speak primarily about some of the environmental determinants of health disparities that can be traced foundationally to the institution of slavery. But before that, I also want to echo some of what was said just now, which is, much better than I will, which is this point of that, slavery wasn't just about violence or the instrumentalization of violence or the legacies of that particular violence on Black folks. Slavery instituted a particular way of seeing bodies and ways of seeing Black bodies, and especially Black women's bodies, as instruments of economic profit, as instruments of labor, as located within particular racial trajectories of exploitation that I think we need to take very seriously, because foundationally, that the ways of seeing Black bodies, especially in the past, have always existed fundamentally as the antecedent of particular forms of what we would call potentially neoliberal practices of seeing humans purely as economic agents, as we see so often and have seen in the health insurance industry, et cetera. So these are not, while these are very serious mortal problems for Black population in the United States, these are not just Black problems. And I think we need to make sure we don't segregate these away in public health conversations. But I want to speak to the fact that we so often separate the history of slavery, especially in public discourse and especially in politics, as a period that has ended, but in actual fact, as we've discussed, the legacies persist to this day. And while the 13th Amendment foundationally rendered slavery illegal under the Constitution, except, of course, in the cases of punishment for crime, the legacies of the racial structures of the United States persisted. And after the Civil War and the rise of Jim Crow and the Black Codes, et cetera, you see, as a result of racial violence and terror, especially in the South, the Great Migration occurs where large African American populations move to urban centers and put themselves foundationally at the mercy of segregationist, punitive, and discriminatory housing practices, discriminatory labor practices that forced us into the poorer, most dilapidated areas of cities or outside of cities altogether. And when you think about public health, place matters, right? Place is always foundational to the health outcomes of individuals. And in these areas that had less access to services, less access to social supports, less access to healthcare, less access to clean water, food, et cetera, in turn structure the health environment in which we see all these disparities taking place today. And that foundationally is a direct result of the history of slavery and its persistence.
So thank you for drawing those 400, actually more than 400 years, so neatly for us. I want to announce for anyone who's just come in recently, there are index cards passing around. We want to hear your questions, and so please write down questions that you have for the panel and pass them towards this end of the aisle, and they'll be collected and hopefully work their way down to me so I can ask the panel. First, I wanted to ask the panelists one follow-up question here, that it's possible to talk about the legacies, the public health legacies of slavery as a field that, a problem that slavery produced, but that the field of public health is currently working to fix. And certainly there are a lot of people in this room, and we're going to be hearing a lot in the second panel about what meaningful efforts are being done to reduce and resolve health inequity today. But over the past century, as we know it, the field of public health has worked at times to augment rather than reduce health disparities. And I'd like to ask you, those of you who want to respond to this, what do you think that every person working in public health today needs to know about the relationship between public health as a profession or institution and the long history of racial disparities in order to more effectively work past these past barriers today?
For me, it has to be about, whether public health workers, medical practitioners are aligned with a social justice imperative that essentially dismantles one of the most pernicious legacies of slavery, which is the kind of fictions that exist around poor bodies and Black bodies. And unfortunately, in many cases, those two bodies are linked. They're one and the same. And so, for instance, in the area that I study, the reproductive history of this country, there are all kinds of myths. We typically kind of, focus our attention on the Black folk not feeling pain, but also there is this pernicious and vicious lie that Black boys who are born are somehow, those newborns are stronger than other babies, right? The ways in which you read these articles and the patients are always blamed. As an academic, I have lived in a lot of different places, and one of them was Mississippi, where I worked at the University of Mississippi, or Ole Miss. And I remember thinking, somebody needs to come down to Mississippi because Black women were always blamed for getting high blood pressure or gestational diabetes when they were pregnant because they were fat or had poor diets. And I was like, well, my Lord, they must have missed Mississippi because everybody down here is big, right? And so why were the stats different for fat white women, right? Somehow the stats didn't seem to equal up. And I'm looking at people who literally look the same in terms of their girth, right? And so the ways in which the racialized fictions around Black bodies still persist, and sometimes those of us who get a couple of degrees, we enter into these spaces, we think somehow we are absolved of our racism or our elitism, and we are not. And so we can create all kind of fancy terms like, thank you, implicit bias. But sometimes we need to heal because we don't believe what people tell us because of the bodies that they're housed in or the ways in which their speech comes out, right? And so those are the ways I would say public health folk and medical practitioners need to really check themselves every time they go into a room, right? And treat people respectfully.
If I may, I just want to add on to that because I think this touches on something that I think we can link and we see so directly relates to slavery in terms of these fictions around Black bodies, and especially the durability of Black bodies, especially in the face of infectious disease. Going back to the 1500s, Bartolomeo Las Casas, who famously put forward one of the first suppositions for or in support of chattel slavery to Spanish-controlled Central America and the Caribbean, said that, I'm paraphrasing, I supported African slavery because up until that point I had never seen a Negro die except by hanging, and that they take to this land like orange trees. And this legacy of African American or Black folks across the Atlantic seen simultaneously as the strongest and the most fragile and the most lazy is a paradox that has to be held very close and very delicately when we think about the practice of public health. And I think about there was a yellow fever outbreak in Philadelphia in 1793, where Benjamin Rush, one of the signers of the U.S. Declaration of Independence, implored the black population the free black population of Philadelphia to stay in Philadelphia and help and treat the white population, which they did, but under the assumption that black folks were more immune to yellow fever than white folks, which they weren't. And they died in large numbers, but did volunteer. However, this legacy is often erased, and black folks are seen purely as servile and not as the saviors of so many folks in the city. But I think this gives us an important lesson, because foundationally, health and public health, in many ways, has often seen the illnesses and experiences and epidemics within the black population only through the lens, or only instrumentalized through the lens of how this might affect the white population. And I think that this pathologization and separation of black experience from white health concerns is something that we need to take very seriously in the present.
And if I can add just to what Sasha said, because it's very important about that 1793 epidemic in Philly. Okay, so this is a plug. I'm the director of the program in African American history at the Library Company of Philadelphia, and we actually have the pamphlet written by Richard Allen, who founded the AME, or African Methodist Episcopal denomination, and Absalom Jones. And they took on the father of American medicine, Benjamin Rush, one of the founders of the country, a signer of the US Constitution. And without formal training in science, they knew that it was a racial fiction, that black people were somehow immune, because they were in the thick of it. And so it really was important for me to be able to see the connective legacy. I saw the way that they moved for y'all, so y'all must be the ministers on the second panel, right? But the connective legacy of black ministers who were at that point the leaders in the community, the intellectual leaders of the community, who sat together, one of them a former slave, and wrote out a treatise essentially saying, we reject your lies about black people, that in fact, you're placing us more at risk, right? And so once again, this legacy of the racial fictions has often been, resisted against by black people who had the gumption and the courage to be able to say, we see the racial cognitive dissonance going on here, AKA a lie.
I think the only thing that I would add to all of that, which is yes, but the only thing I would add is that there's a saying that people say, particularly organizers on the ground, about who are struggling against class differences and access to resources, and it's that poverty is not a moral failing. I think we can apply the same thing to health and to disease, this idea that there is a moral failing if somebody has been marked as obese, if somebody has diabetes, if somebody has cancer. And instead, what I would ask as a historian, health professionals, is to treat these as having histories, as constructed, as having social realities that have nothing to do with someone's moral reality. It has nothing to do with whether they are to blame for their condition, and instead are part of both history and environment. And thinking in particular about the ways that some of our most pernicious health concerns of the modern era of the 21st century, I just mentioned diabetes, are also legacies of plantation products. Sugar is a legacy, is the progenitor of the sugar craze that has taken over since the 1500s. Tobacco, coffee. The most addictive products, they became cash crops because they are addictive. And that is how the Americas were made, how so many billions of what are now dollars of wealth got created. And I think the next panel is also going to talk a little bit about what now might be owed in return for that. But I think as health professionals encounter these as diseases, as health conditions, it's important to keep those in historical context and move out of a kind of blame-centered practice that seems to sometimes come up.
Just very quickly, I'd add that anytime that there's a racial bias in public health studies, especially those having to do with the frequency of performance of certain procedures, the pathologization of those people's physiques under scrutiny needs to be questioned. And we're talking a lot here about how maternal mortality is always political, and also, Deirdre already brought up the fact that Black women are 3 to 4 times more likely to die from pregnancy-related causes in this country. And so one thing that's very important is addressing higher rates of cesarean deliveries in African American and Hispanic women, because unnecessary cesarean sections are very important to reducing racial inequalities and maternal health outcomes. And so an important study came out of the Harvard Medical School a couple of years ago, which showed very clearly that the correction factors that were assigned to the calculator for trial of vaginal birth after cesarean section were racialized in such a way that these correction factors subtracted from the overall likelihood of a successful vaginal birth after cesarean, so that women who identified as African American or Hispanic were systematically assigned a lower chance of a successful VBAC than white women. So for example, a 30-year-old woman with a BMI of 35 and 1 prior cesarean would be assigned a 46% chance of successful VBAC, whereas a woman who was either African American or Hispanic would be, with that same BMI and the same history, would be assigned only a 31% chance. So while many factors were identified in the preliminary study, such as insurance type, marital status, social disadvantage or advantage, the only one to make it into the calculator was race. This was the only one that was incorporated into the final predictive model. And so when we're talking about public health crises, it's, of course, the historians here would always say that it's extremely important to then look at where those anthropometric biases that pathologize non-whites come from, which is the 19th century. And so to question then these racial biases that are incorporated into the calculators that we're using.
So we're starting to get a number of questions from the audience. Please keep them coming, and if we don't get to your question, we will be reading all of the questions and certainly use them to inform future events, so please keep them coming. One question from the audience here. Do you think that health disparities would be as severe if medical systems and public service systems had remained segregated?
Will you repeat that?
Yeah, so this is a question thinking about the legacy of segregated health systems, segregated hospitals, and the question is, do you think that health disparities would be as severe if medical systems and public service systems had remained separate?
Ooh, this is interesting because it's a kind of question of a coin that, the coin of two sides. So this is the thing. When we think about, too, what my colleagues have talked about during this colonial era across the Atlantic world, and in particular what becomes the United States, although there had always been anti-blackness based on a kind of foundation of white supremacy, notice those white doctors were oftentimes treating and experimenting on black patients and still treating and experimenting on white patients, and there was no separation. The separation literally becomes institutionalized and codified during freedom. Now, that doesn't mean that there had not been, kind of separate black and white spaces, but if we even look at, the kind of, he's the most famous president, white president with a black family, we look at Thomas Jefferson, right? Here this man had written these ideas about black people and blackness and biological distinctions between white people and black people and native people, and yet he had a bedroom built in his home for the black slave woman that he owned and had sex with. And so there had literally been no separation. How can there be separation when a labor set is created off of black women's reproduction? Wet nurses. They didn't send black women out to a black space. They brought those black women into white homes to nurse white babies. And so the separation comes literally after in a kind of codified way after slavery ends. So that's one thing. Unfortunately, because people are being educated in racially integrated spaces, and they're utilizing some of the same texts, oftentimes you will have physicians of color that is, kind of a coded language for Black folk, because that's essentially who we're talking about, who still believe the same things that white physicians believe, because they're getting anti-Black information that has been produced in those textbooks. Think about Tuskegee. That happens in a Black space in partnership with the government, right? They didn't have to go to a white space. They were at a Black college in the Deep South, in the Black Belt South. So it's a double-edged sword. I think what is, at least for me, a really wonderful thing that has been happening, particularly since the late 1950s and 60s onward, you now have people of African descent who are creating organizations, as Liz talked about. They are reworking narratives where they are essentially resisting some of those kind of outdated and outmoded ways of thinking about treatment and health and race and class, and really pioneering ideologies and practices that are more precise and accurate. So yes and no to that question. Thank you.
I'm gonna obliquely get at the question, because I think I want to challenge what might be one of the built-in assumptions behind the question, which foundationally is that in the absence of white care, Black folks would not have health care. And thus, a separate but equal, or a separate structure would still mean that white doctors are treating Black patients. And I think I want to get at this because I think it's important to think about some of the legacies of slavery that are more historical and theoretical than they are necessarily explicitly material. And that is the erasure of Black expertise in medicine that goes back to slavery and before. I'm going to plug your book, Dr. Cooper Owens. You've written extensively about the role of Black female nurses, medical actors in developing, American gynecology. There were slaves in South Carolina in the 1700s who were, and 1800s, who were freed because of their knowledge of snake bites.
That's right.
The history of Black medicine and Black medical actors has largely been erased, and in large part as a result of our misguided beliefs around slavery and around the inability of Black folks to uplift and gain knowledge without white actors. So I think this is an important assumption to challenge when we think about these sorts of questions.
So I want to bring in, sorry.
Really quickly, I think the only thing I would add to that, because I think it might be important to kind of separate out the knowledge, like medical knowledge, and not supporting, not privileging Black medical knowledge, like African diasporic medical knowledge, and segregation. And the only thing the way I would ask us to think about it is that segregation is about managing resources. It's about a state-sponsored system that can divide and conquer resources and can extract resources from the Black community and put it in the white community. Like this tax base is everybody's tax base, but only white schools get funded. Like that's in some ways the underlying economic logic of segregation. And so in that sense, the divestment of actual resources from Black doctors, Black medical professionals is also one of the sort of pernicious effects of segregation. So I don't know that staying with segregation would necessarily help with Black health disparities. What that means, though, is that what are the ways that, like you guys are saying, like we're saying, that Black medical knowledge can be recentered in public health? And I think that that's an important conversation that does, like you're saying, decenter white doctors, white medical knowledge, white professionals as sort of the arbiters of health expertise. And what do we do if we think of like the legacy of enslaved Black midwives who did have their knowledge, extracted essentially to create the medical profession, in the period that Dr. Cooper in particular studied. So that's the only thing I would add, that state-sponsored extraction of resources is actually the key piece of segregation that did need to be dismantled in order for, some more equitable spread of resources across. Now, has that happened since? That's that's a struggle. That's I think some of the struggle as well as the knowledge piece.
So another question from the audience, very on point for this panel. How have Black people internalized health disparities to believe they are powerless over health outcomes?
What's the last
And what can be
part,
done about it?
Jeremy, you said that they are powerless.
To be powerless over health outcomes. And I will just add what can be done about it. But the question is of the internalization of these forms of difference into a form of fatalism, and what kind of agency can be restored.
I don't have a response to that. As a historian, I wouldn't necessarily think about it in that way, but some things that come to mind include the importance of not seeing, for example, what people refer to as medical mistrust, following the Tuskegee syphilis experiments, as not seeing that as a fixed cultural marker, right? And that instead we need to actively pathologize racism, because it is pathological, and it is a problem on the part of the people and systems and institutions enacting the racism, and so I don't have the response to the internalization question.
I think for those of us who think about that question, we can look to history for patterns of resistance. Jennifer Nelson has a great book about women of color in the reproductive health movement that looks at the ways in which claims that were specifically against and attempted to recenter Black women's health narratives to conversations about abortion rights, Roe v. Wade, et cetera, really transformed the conversation. We can also look to the Black Panthers, because I think who are essential in this. Regardless of what many of us might have learned about the Black Panthers, large aspects of their most successful projects were, community farms, food, and foundationally community health centers that attempted to democratize health access in ways that transformed doctor-patient relationships, focused on neighborhood health disparities and issues that were there that existed and operated outside of the kind of regime of the American Medical Association. And I think it's important when you think about when we tend to despair, but first and foremost, we can look to the past and look at moments where there has been serious and effective resistance to these problems and possibly transform that into our future.
I'm going to attempt to also answer this question, but I'm going to do so using the kind of historical tools I was given as a grad student. So bear with me, whoever wrote that question. So at the heart, you're getting at two things, at least from what I'm hearing. The internalization of essentially anti-Blackness, right? How does that affect the disparity in health outcomes, right? And I mean, let's be real. This is something that Black folk all over the world still deal with, right? The kind of internalized anti-Blackness, right? And so from the ways in which one wears their hair or tries to lighten their skin, or whatever it is, that internalization has happened in myriad ways. So yes, that's an issue. I think the kind of health disparities that come out of that are seen in the ways that racism based on anti-Blackness has affected Black bodies. There's a wonderful, let me take that word back. I'm gonna remove the word wonderful. It's wonderful in terms of, for me as a researcher, but it's not wonderful in terms of what these researchers found. So a team of physicians and research scientists at the University of Southern California and UCLA, and this was just maybe a month or two ago, published an article that spoke about the ways that racism essentially makes Black people sick, right? And so sometimes it's not what you do, it's what you imagine. Think about the physiological responses that you have if you go into a store and you suspect someone's following you. They might not actually be doing it, but the ways in which your body responds creates, a sense that you're overheated, your heart might start racing. And so you have enough of those responses, it can make you sick because it becomes a stressor, right? So they talked about those kinds of things. So that might get at the heart of the internalization question. The other thing is, though, and I'm going to do what my colleagues have essentially done, I think about the ways that people have used their power to work against medical racism. So what that means is, even though we may not have the historical sources, just in our conversations, in the ways in which we've been taught to kind of read between the lines, because we kind of, we deal with people who died a long time ago, and many of those people who died a long time ago were not allowed to become literate, so they didn't leave a lot of written records for us. But what we can do when we read between the lines is to see the ways in which they created community by creating informal networks of communication. And that's something that had been passed on to their descendants. What they did when they were allowed to create formal networks, right, that protected them and their interests. They created community health centers. They created various modes of communication so you knew who to go to and who not to support. Right, those kinds of things. They knew in spaces in the Black Belt South, like Mississippi, Arkansas, Louisiana, Tennessee. We tend to only know about Mississippi because of Fannie Lou Hamer, but those Mississippi appendectomies, where Black women were literally having their uteri removed against their knowledge, right? Not even consent, because they didn't know. So these Black women in communities, I had a conversation with a group of older Black women from Arkansas who were in their early 70s to late 70s, and they talked about the ways in the Arkansas Delta that they knew doctors to avoid so that they wouldn't have hysterectomies at 21 and 20. Those things are not in books, right? But we know from the ways in which Black people have inherited these ways of trying to protect ourselves, our bodies, our interests, that they existed. And so I'm always thinking about the ways that people extracted power in a society that was meant for them to be powerless.
So
I think really quickly, I just want to say, I really want to co-sign that, because I think, and I want to repeat again, poverty and disease, these are not moral failings. And I want to make sure that we're not thinking of Black people's mistrust of the medical establishment as equaling a fatalism in the face of health disparity. That in fact, historically, since slavery, we have been working very, very hard in the face of resource extraction to protect, maintain, and keep hold of our bodies as well as ourselves. My work is centered in New Orleans. The extent to which Congo Square becomes a space of dance, of festivity, of play, of community creation. It's also a place where people were selling and buying food. It's a place where people were practicing various African-derived spiritual traditions. So there are ways that Black people historically have created these spaces, and that those then become a foundation, as you're saying, to institutions later on. And I just think it's important that we do not paint a broad brush on people of colors, Black people, African-descended people's understanding of where and how they can access doctors with how they feel about their bodies. And that, in fact, some of this actually speaks to like the way that Black knowledge has of Black medical knowledge sort of becomes segregated, is there an extent to which sort of it being loosed from a kind of whole sense of the body, not just the science of the actual physical, bodies, blood, and cells, that actually we need to make that tie again. And then people are doing that really actively right now and have been doing that for some time.
So that's a great way to begin to segue to our next panel. An hour goes so fast, and there's so many good questions from the audience. I want to leave one question with us, maybe to linger in transition, which is that this underscored a number of the comments from several of you. The question of reparations for Black Americans for the violence of slavery has been a lingering and for many a burning question ever since General William Sherman, the promise of 40 acres and a mule for all Southern freedmen was undone by our first impeached president, Andrew Johnson. And reparations has been taken up quite avidly this year, right, with congressional hearing in June following Baltimore's Ta-Nehisi Coates and 4 Democratic presidential candidates expressing support. And the question I really have for you, there's not time to answer it, but we could take it into the next conversation and leave with it, is how does the conversation we're having today about the measurable legacies of slavery on the bodies of African Americans today intersect with the current case for or against reparation? What does a public health perspective on reparations look like, and how does it inform our conversations? But please join me in thanking this panel for such extraordinary conversation. And I could stay all day when we wouldn't have enough time for this conversation. But thanks again, and I think the next panel, Dean McKenzie.
So good afternoon, everyone. I'm Lisa Cooper, and I direct the Johns Hopkins Center for Health Equity here, where approximately 40 health equity researchers work in partnership with our communities to address health equities in Baltimore and beyond. And we really believe in the importance of person-centered and culturally appropriate approaches to building strong relationships with members of our communities, including them as equal partners with valuable knowledge and lived experiences. So when it comes to conversations about health equity, we've learned that we should think as much about who is not in the room as who is. And our earlier panel was about understanding conceptually how the past has influenced our present circumstances, particularly for African Americans. This panel is about understanding how these problems manifest themselves today, right here in Baltimore, and what health and public health professionals and scholars, social scientists, and community members whose daily lives include experiences of inequity in health are doing every day to address this problem. Our future conversations, as Jeremy mentioned, we should have many future conversations, and Dean McKenzie as well as Josh, should include more of these individuals. And we should also include local and national policymakers who are in positions of power to make the structural changes that are actually needed to help bend the arc of history towards justice. So we'll start our first aspect of this conversation today. So I want you to join me in welcoming our panelists, who are Dr. Janice Bowie, professor in the Department of Health, Behavior, and Society here at the Johns Hopkins Bloomberg School of Public Health, Bishop Douglas Miles, who is a pastor of Koinonia Baptist Church and co-chairman of Baltimore's United in Leadership, or BUILD, Reverend Deborah Hickman, who is president and CEO of Sisters Together in Reaching, Incorporated, Dr. Karen Cruz Thomas, who is historian here at the Johns Hopkins Bloomberg School of Public Health, and Dr. Lawrence Jackson, who is a Bloomberg Distinguished Professor in English and History at Johns Hopkins University Krieger School of Arts and Sciences. So thank you for joining us today. And I'm going to basically have each panelist give a few introductory remarks about themselves and their work. So we'll start with Dr. Jackson. As a native of Baltimore and a writer and historian, you've written about historical forces, including mass incarceration, housing segregation, and disparities in healthcare and education among African Americans, driving the unrest in your hometown during the civil rights era, and then now more recently after the death of Freddie Gray while he was in police custody. Please tell us more about how these historical forces have shaped the lives of African Americans in Baltimore.
Is it all right if I use the lectern?
Pardon me?
Can I use the lectern?
Well, we'd prefer if the panelists remain seated, and we'll just have the AV folks to put up your slides for you.
They're right there. I think they're right there on the computer.
Am I supposed to press something? Okay. They're here, but, okay, we got it. Okay, thanks. There you go.
I'm a lay person. I've never been in a public health school or medical school or anything like that. And the comments that I have to make about these subjects, I mean, they really are coming from my own personal experience. My father's grandfather was born in slavery in 1855. He lived for 10 years as an enslaved boy. He saw his family sold in 1860. These are circumstances that I learned about as an adult. I was born at Sinai Hospital here in Baltimore, at least in part because my mother didn't want to deliver at a segregated hospital like Johns Hopkins. So in many formidable ways, I think so much of our own lives as Black people are shaped by these very strong and salient legacies of enslavement. When I was in the 10th grade, I created a social group with the guys from my street. I grew up on Dowfield Avenue in Northwest Baltimore. We mainly wanted to have the social group to have fun, but we were always quite conscious of the violence that was ubiquitous throughout the city. I was always very conscious about my surroundings, and we were wanting to be able to protect one another. And we used to joke about in the early 1980s, we used to joke about the homicide rate and the likelihood of reaching the age of 19. So the group was called the Oxfords because I was going to a Catholic school and I wore Oxford shirt and tie to school every day. And we were also called throughout the city, we were known as preps. When the days that I used to have off from high school, we would go to Walbrook Senior High School or Carver Senior High School or Forest Park or to Poly. We would go to the lunchrooms and hang out. We wanted to have as many friends across the city as we could. And it was the term preps for us was a Black term of difference, but it was connected to the term preppy. I mean, it was related, but not the same. The pictures that you see here are from 1988. And most of them were taken at two nightclubs. One was called Nightclub Fantasy on Howard Street, and the other one was Godfrey's Famous Ballroom on Charles Street and Landvale Street. Everyone in the pictures, they either attended, at least for a time, a four-year college or a community college, or they joined the military. But however, nonetheless, everyone's lives were very strongly affected by heroin and cocaine. Some people became schizophrenic. Some did go to prison. Some suffered from kidney illnesses and diabetes and lost their lives. Some are suffering now from cancer. And a very good friend of mine who was in all three of the pictures, Donald Bentley, was killed the next summer. Would you show the next slide? Yeah. So that was the cover of the Afro-American newspaper. And this is a picture that we took the night of the wake for Donald Bentley. The death of my good friend Donald was shot and killed on Maryland Avenue. Definitely inspired me, I think, at least to take the opportunities that I had more seriously, and also to develop my own writing as a means of understanding, especially the regularity of urban violence. So I wrote a lot of elegies over the years, over many years, and then also when I lived in Baltimore in the 1990s, when I was teaching at Howard University, I would write a bit of journalism, op-ed pieces, typically dealing with the epidemic of street crime and street violence in the city. And for me, just concluding remarks, it has culminated with my return to Baltimore. In 2015, I was teaching at Emory University, and when the uprisings broke out, I saw on the C-SPAN or CNN my friends Daryl Green and Cordell Hunter. They're both Omegas. They were in the middle of North Avenue by a bar or some establishment that Cordell Hunter was connected to, and they were concerned about losing their business. But it was very surreal to see people that I had known in that circumstance. And I turned a class that I was teaching, Introduction to African American Studies. I took a 180-degree detour, and I broke the course into a series of research modules on mass incarceration, residential segregation, health disparity, and educational inequality. And the students made connections with community groups on the ground in Sandtown, and at the end of the semester, a third of the class came to Baltimore and made presentations. I wanted them to work basically as like think tank with intellectual resources for community groups. And during the course of the comings and goings and, thinking more seriously about joining the Hopkins faculty, I started working on an article about the uprising, and the cover of it is, or the opening and closing of it are behind me. But it concludes, the final sentence of it is, sort of as I look at the trial and the police officers and knowing people who went on to join the police force and knowing people who went on to give so much of their lives to the streets, and really trying to make sense of this, and then thinking about the point of view of the young people, the article concludes, a riot makes a lot of fucking sense. So that's where I would leave my opening comments. Thank you.
Thank you, Dr. Jackson. So, we've heard about one of the well-known public health legacies of slavery, which is this violence that we see in a lot of African American communities, where a lot of African American young men succumb to violence. And, we've heard that one of the things I've heard about the statistics on sort of where Johns Hopkins School of Public Health focuses a lot of its research. One of the things that we commonly hear is that, a lot of this research is focused elsewhere in the world, and it's not really focused on many of the issues in Baltimore. So we're going to turn to Dr. Thomas, who has studied the history of Johns Hopkins Bloomberg School of Public Health and published a book about this entitled Health and Humanity in 2016. So Dr. Thomas, could you tell us about the historical factors that led to the establishment of Johns Hopkins School of Public Health in Baltimore, and how, some of the historical events of that time actually shaped the Baltimore community's view of this institution, as well as its current focus and its focus of research over the past few decades?
Yes, thank you. So the first chapter of my book, Health and Humanity, is called The Southern Roots of Public Health at Johns Hopkins. The school was chosen by the Rockefeller Foundation as the site of the first school of public health. We basically won a competition for a grant from the Rockefeller Foundation. Johns Hopkins was selected among Columbia, Harvard, and University of Pennsylvania and Hopkins, very much because of the presence of William Henry Welch and the strength of the medical school here, but also because Baltimore was the southernmost of the four schools, and because we had, as the application put it, the most interesting diseases. We were the closest to the Caribbean and Latin America that was the focus of the Rockefeller Foundation's work in its International Health Division. We were a port city, and we had diseases that were more like the global South. But just as medical schools built on the Flexner model were looking for, as administrators put it, clinical material for doctors to learn how to work with patients on, the School of Public Health was also looking for people and neighborhoods to practice public health on. So there was a Eastern Health District created in 1932 that became a model for public health administration and research and teaching around the world. The Rockefeller Foundation took it up and helped spread it to other places that it supported financially. But that was the 1 square mile neighborhood around this school, the Eastern Health District. And eventually that area was nicknamed the most studied people in the world. I don't know if that was absolutely true or not, but in its early years, the Eastern Health District had so much potential, and some of the earliest and most profound epidemiological studies were done there. But as time went on, especially after World War II, the most studied people in the world got tired of being studied. And there became, more people began to resist and call out the health commissioner of Baltimore, Huntington Williams, and say, basically, I've seen the postcards in the Chesney archives. Shout out to the Chesney. We're tired of you coming to our doors and asking us how many toilets we've had. The researchers asked some very personal questions, such as, how many abortions have you had? So our desire for knowledge sometimes crossed the boundaries into insensitivity, and we eventually stopped our work in the Eastern Health District because both the city health department and the surrounding community grew tired of being the subjects of our research. Now, so should I stop there?
So,
for time's sake,
I think that's a very
take anyone
good
else's
sort of
time.
background for
Yeah.
people to know where the school started out and what its relationship with the community was early on. But we also know that, there were other problems going on outside of the school. So we know that there was segregation going on and a lot of and poverty, racial discrimination, and reduced access to health care, all of these things that undermined public health efforts. So we're just trying to figure out if we can learn a little bit more from you about what role the school itself played in that piece, what were some of the good things that it did or might have done, and what were the things that weren't maybe not so helpful.
Right. So my work as a historian before I came here to Johns Hopkins was looking at the civil rights movement in medicine, and especially the conditions of segregated health care and how that system began to be dismantled by the medical civil rights movement, especially physicians at Howard, such as Paul Cornely and Montague Cobb, who led, another speaker earlier mentioned the National Medical Association. But those black physicians began to push back against segregated hospitals, against unfair treatment, against the unfair distribution of resources to white hospitals more than black hospitals, and especially against the practice of not allowing black physicians to have admitting rights because they did not belong to the local chapter of the American Medical Association. Okay? Now, here at Hopkins, the local National Medical Association chapter was called the Monumental City Medical Society. And its leader, B.H. Retta, began applying to our school in 1922. He was very persistent, and he continued to apply, and he continued to be turned down. Now, we were a private university, and we could theoretically have accepted black students because we weren't governed by the same laws as the public institutions. Nowhere in the state of Maryland, in the public system, was there the opportunity for black students to pursue graduate or professional education until very on a token basis in the late 30s, but really not until the 1950s. However, our school, the school of what was then called the School of Hygiene and Public Health, in 1945 became the first division of Johns Hopkins and the first historically white university in the South to admit and graduate a black student. And a couple had been admitted, but no one had actually graduated, which spoke to the kind of conditions that students faced when they got to campus. But in 1946, Reginald James, a U.S. public health surgeon, graduated from our school with a Master of Public Health. He later becomes one of the whistleblowers on the Tuskegee study. We continue to admit black students. It's not a lot, but it's consistent over time when other schools and universities around us were not. So of that, I think we can be very proud. So I'll stop there.
Yeah. Thank you, Dr. Thomas. So, I think what we're hearing is that there's a complex relationship that many institutions had with the society during over time, over history. And so we know, Bishop Miles, that you are a native Baltimorean and also have some lived experiences with some of these institutional challenges, having been one of the first African-American graduates from the School of Arts and Sciences at Johns Hopkins, as well as a founder of the Black Student Union there. And that now that you are an esteemed faith community leader in our community, we wanted to talk with you about what role the Christian church has played in creating the legacy of slavery that still exists, and also, on the other hand, what role has the Black church played in being a voice and pushing back against that legacy? And Reverend Hickman, feel free to comment on that as well, since we know you're also a faith leader.
Well, let me begin by credentialing myself a little bit differently as being a native Baltimorean and one who experienced the last vestiges of legalized segregation in Baltimore. Those of my generation experienced that. Those of my generation knew Baltimore when Sinai, Johns Hopkins, and St. Joseph's hospitals were all located here in East Baltimore. And many of us experienced the legalized segregation of those institutions against the African American community. Secondly, let me credential myself as a historian and a theologian. So I will approach this from both a historical and theological perspective. As we think of slavery and every economic institution that has come about in the world, those economic institutions have been undergirded by theology. And slavery was undergirded by theology. And that theology did not begin in the 15th or 16th century. It goes back to when Constantine embraced Christianity for Europe, and Europe stole Jesus, bleached him, and made his hair blonde, because Europe could not countenance being under a Semitic savior. Now I know folk are laughing or finding it kind of, but it runs to the heart of racism and whiteness, undergirded by a theology that denied a people's humanity. Because when you look at theologically and historically at the construct of the world, there is no such place as the Middle East. It's Middle East of what? Of a European construct of the world. The Middle East is North Africa. So you have to go back to that point to begin to understand the impact that white Christianity had upon race in the world and how it has played out economically through slavery and every other major institution in Western society. Many people think in terms of Maryland being, and many people in Baltimore think of Baltimore being a northern city. It's a southern city that thinks it's northern. It's really a southern town that thinks it's a northern city. Maryland is below the Mason-Dixon line. That's right. And even though Maryland never seceded from the Union legally, it seceded theologically and philosophically from the Union. The white church in Baltimore and Hopkins played a major role in this, helped to put forth the philosophy of eugenics, which rated people in the world as to their viability and their intellect. And of course, Protestant, male, white, and upper class came out at the very top. And at the very bottom of that construct were African Americans and Mexicans. All of that has played out in how healthcare has been distributed in this nation, in terms of how poverty has been a legacy that has crippled and continues to cripple the African American community. And I don't want to talk about people of color. I want to talk about black folk. Because there's no other people in the world other than African Americans who've had their culture, their language, and their heritage stolen from them. Every other people in the world can trace back to where they came from, except African Americans. The best we can do is say we came from a continent, but we can't even identify the nation that gave us birth. So when I talk about this issue of race and whiteness, I talk about it from an African American perspective, because when African Americans prosper, everybody prospers. Amen?
Amen. Amen.
So let me stop there.
Thank you, Bishop Miles.
I dare not want to add to his comments.
Right. But you have your own story to tell, Reverend Hickman. So
Yes.
tell us about, we know that you were born here in Baltimore. Your family moved here from South Carolina. And tell us about how the legacy of slavery impacted your health. What vestiges of slavery did you see while visiting your family back in South Carolina? Also, while growing up as a young woman here in Baltimore, a young African-American woman in Baltimore. And we know from previous, hearing from you previously, that you are one of those people who has found your voice and used it. So tell us more about how you got to that point.
Okay, so I'd like to start by telling you about how I found my voice, as well as my experience, my life experience, and the legacy of slavery from my perspective of my parents. I cannot go anywhere without talking about what happened to my parents. My parents were third generations in slavery, lived on sharecroppers' land. When they left South Carolina, they were living in Clarendon County. We had family in Sumter, South Carolina, and Charleston, South Carolina, and believed that we even might still have some family in the Gullah Islands. And so when they moved here, they were very young in 1947. They were somewhere between the ages of 20 and 23, waited about 8 years before they conceived me. And they moved away from a very spiritual family. They moved away from a very committed community to stay together and work the fields, the cotton fields, the tobacco fields, and the like. And the environment of the South, they knew how to live and who was and who wasn't, and considered themselves moving north because they believed that if they could come here, that they would find some greater wealth than what they were experiencing at taking tobacco off the stick for a half a cent, at picking cotton all year, a bale of cotton for less than 5 cents a bale. And so when they came here to Baltimore, they came with the little they had, but they already had one sister. My dad had one sister that was living here with her husband. And so that was the only family they had. Those were the only friends they had. And soon my father's brother followed him in suit, and they found jobs here in Baltimore City, building houses along Loch Raven Boulevard that before my dad passed, he could show us where those homes were. But he did not end his work life there. He also worked at W.R. Grace and Company. My father and my mother were both illiterate in terms of reading and writing. And so at a very young age, when my mom had me, I can only believe that she became depressed at realizing that she had not been able to really live her life, that life for her as a young woman had been stripped away, and that she had 2 children now looking at her, and she herself still had to work. She cleaned houses and she waited in restaurants and cooked. And along those lines, when she came home, she began to do what she did not do in South Carolina, and that was to drink. And no one asked, and no one, as she gave birth, asked her about her past or what was taking place with her. I would like to say today, I believe that my mother had postpartum depression. My mother was a functional alcoholic, and she made sure that the house was clean. She made sure that the meals were on the table, that my father had a bag lunch going out the door each and every day. As we grew, my brother stayed very close to my mom, and I stayed very close to my dad. My mother and father found the church, Wayland Baptist Church, here in Baltimore City under the pastorship of W.W. Payne. And my dad and I would go to church faithfully every Sunday. My brother and my mother would go here and there. Long story short about that part of life was that my mom, while she was home and taking care of business, also not only fed us, but she would feed the entire neighborhood. And when we lived on the west side, on West Lexington Street, the 1800 block, we understood that if you did not have, you weren't going to have. But we had neighbors that would open their doors twice a week to feed us when we couldn't feed ourselves, while my dad was walking to work at 3 a.m. every day to make it down to W.R. Grace by 7 a.m. And he walked home every day unless someone gave him a ride or unless he could get his car fixed. My mother drank more and more. And at the time, we were renting our apartment from Gold Seeker. Anybody that knows anything about Gold Seeker knows that there was the biggest injustice there. And that he would come to collect rent. And every time he would come, it seemed to me as I stood there alongside my dad that he was asking for more and more money that took more and more food off of our table. And so one day I looked at the rent book and I said to my dad, "He's cheating us." And my dad said, "Girl, be quiet." Well, one day he wasn't home, and this man threatened that he could evict us if I didn't shut my little mouth. But I didn't shut my mouth. I showed my dad, and I even showed them that we should be able to call the police on them because they are stealing from us. So I got a voice at 8 years of age. But every summer we would have to spend my brother and I would have to spend our summers, the day after school until the day before school reopened in South Carolina. Is where I got my lesson about having to string tobacco, having to take off tobacco, having to load the truck up to take the tobacco from South Carolina to Georgia. And I was taking off tobacco for 1 cent a stick. And so one day when we left the barn of taking off tobacco and stringing tobacco all day long, we went home for what you all call lunch, we call dinner. And when we got home for dinner and we just sat down to the table, the master came and said, "Miss Amanda, I need you to gather those children up, put them in the truck, and we're going up to the watering hole because we're having a big dinner tonight and we need you to pick beans." And we went up to the watering hole and there was no shade, nor was there any water, and the sun was beaming down on us. And I looked at my grandmother and I said, "This is not right. Their family is eating and we're not, and it is no water out here or anything." And before I knew it, I was on the other side of the bean patch because he said to my grandmother, he was like, "Thank you, Miss Amanda, because I didn't want to have to whip the girl out here. And I sat there and I cried and I cried and I cried. And from that time on, that man did not know that he unleashed something in me that I said would never happen again. And from that point on, I had a voice and I used my voice. I had rage in my belly as I watched my mom die on our sofa, literally, from drinking and drinking and drinking till as I grew up and went to school at Mervo to become a licensed practical nurse, believing that if I could do nursing, then we could move out of poverty. And that meant something to me because my dad always took me to church, and that's what I would remember, that people are good, learn what to say and what not to say, when to speak and when not to speak. Well, I never got the last lesson very well, because many of you who know me know that if I have something to say, I am going to say it. I don't really like to be in this space at this time of black and white because we have but one God that seemingly never gets raised a lot in these conversations that we have, because people are too busy trying to believe that they know what God has said and what God has done, and have really never been at the midnight hour with God to know what it is that they're supposed to do. And so I got that voice, and I use that voice today to advocate for women, to advocate for men, to advocate for youth, but to advocate for all of us to let's get the story right at this point in time in 2019, that we serve a God that made all of us, and he did not make us with the disparities that we have. And he did not make for one group of people to lord over another group of people, but he made us to live in harmony with him. And so I am going to stop there.
Thank you. Thank you, Reverend Hickman. As you can tell, all of our panelists have stories, and Dr. Bowie, we know you also have a story, but what we'd like to do is to shift a little bit, so we'll let you tell part of your story, but we want to shift into talking a little bit more about what we're doing to address these issues. So I'm going to ask you, Dr. Bowie, since you've had a long and productive track record as a scholar, educator, and practitioner in the science of community engagement to address inequities in health, tell us what we know about why that is so important, whether it actually does lead to differences in health or in the quality of research, and why you have said that we need more scholarship led by people with lived experiences in this arena.
Thank you very much, Dr. Cooper, and thank you to all of you who are still sitting here at 20 of 5. If you want to stand up and stretch, this might be a good time. I think that the panelists before me have certainly laid out the story quite compellingly, and what I would like to share is about my experience here as a member of the faculty of the school. I also trained here, so I've been here for a while, as you can tell from my face and my hair. But what I think is important in response to the question that has been posed to me is, what is the value that I see with respect to research that includes communities in the process of understanding what is important to them and to the conditions of health that we see today. And I want to start by saying that even though this is 2019, the faces from 1619 to 2019 are the same faces. The methods may be different. We may not be whipped with a strap by a master, but we are now being shot in the back by a different master. And what's important about that for those of us who are in this school and are responsible for the scholarship and the training that we do is that we have to ask ourselves, are we missing opportunity? Are we going to move forward and be active, or are we going to remain frozen at this point in time? We know, as you've heard from everyone who has spoken, and for all of those who have not even spoken, you know the disparities that exist, that persist. You know, we've called them out: maternal morbidity, mortality, maternal mortality, chronic diseases, addictions, alcoholism, all of these things that we know that people, particularly Black people, die of prematurely, and oftentimes die in ways that are not, where they have no say about how they die. All of those issues we know are very, very much in the lives of people. And for those of us who train here, who are responsible for the research that we conduct, for the students that we teach, we have to think about why these problems persist. And are the methods and the study designs and the approaches that we're using, are these approaches still the right ones? Or are we thinking about them too narrowly? We know that over 70% of these problems are not being solved by medical technology or by clinical care. We know that more than 70% are based on behaviors, social drivers, where people live, what things they have access to, whether they have houses or whether they're living on the street, whether they're having fair and equitable exposure and access to resources, whether their water is clean and drinkable. All of these social drivers are environmental conditions are accounting for many of the problems that we're seeing. So is our scholarship, our curriculum, our training aligned with addressing those? And I want to go back to something that I think Dr. Thomas mentioned about our institution. We're making progress here. We have incredible talent. We have an amazing group of people in the leadership of our school. Our dean is here on the front row. You can slip some notes to her and you can tell her what you think, she should do more of or less of. I can't do that, but none of you can. But seriously, my point is that we have the talent. The question is, do we have the wherewithal? Do we have the will? We have the resources. We may not have all that we need, but I believe that if we are committed and believe in wanting a just, fair, and healthy society, then we will need to think about some of the ways in which we train more broadly. I also want to just say to Dr. Thomas's point that we are the leading school of public health when it comes to admission of Black students. We are not where we should be, but we are, when we look to the other schools of public health, we look better. But we can do better, as our late Congressman Cummings would say, that, we can do better. We need to do better, but do we have the will to do better? And so, Dr. Cooper, I will stop there. But I would close by saying the evidence of engaging those populations that tend to have the least amount of voice and that are often invisible, that are often left out of the decisions about what research is done, how it is funded, what treatments are available. Oftentimes, the very people who are the recipients or the beneficiaries are those who are left out of the conversations, not at the table. And in order for these solutions to be found and lasting, we have to have their voices be present and accounted for.
Thank you, Dr. Bowie. So I'd like to take this opportunity to invite the audience to send in any questions that you have or to raise your hand if you have we'll take a few questions. And just a reminder that this is just the beginning of a much longer conversation. We have lots of issues that we still haven't come to, and we have panelists who are actually actively engaged in the community, leading coalitions of people across sectors, and leading advocacy organizations. So we really want you to have the opportunity to hear about their experiences. Questions?
Good afternoon. My name is Kobe Little, and I've had about a 30-year relationship with this institution. And one of the things that we know about Johns Hopkins is that Hopkins prides itself on its academic rigor. I'd like to distill the whole discussion about the legacy of slavery to a very minute or finite point. Slavery was the denial of the humanity of human beings. Okay? And the legacy of denying the humanity of human beings is that you don't see their needs and you don't address who they are, what their aspirations are, and you don't include them. And that's the case across all disciplines. So to overcome the negative legacy of slavery, two things have to happen. First of all, you have to stop denying the humanity of human beings. And that has yet to happen in Baltimore or anywhere else in America when it comes to people of African descent. That's one. And then two, you have to make repair. Now on this point about rigorous scholarship, every person in this room should have been outraged. And really this conversation should have stopped when a person with a doctorate on the faculty of this school referred to unethical, criminal, violent behavior by public health scientists here at this institution as insensitivity. That's outrageous. And as long as we continue to accept that kind of outrageous language and allow people to be apologists for the past in a way that maintains their own white fragility, then we will never see the humanity of the people who were subjected. Can someone say Julietta Lax's name today and then call what was done to her insensitivity?
Yes.
It's just wrong. And as long as we have that kind of apologism passed off to scholarship, we're not going to be making the gains that we need to be making. And I'll close by saying, about 5 years ago, I said to my good friend Ron Daniels, is this university prepared to use all of its strength and all of its power to oppose and to eliminate white supremacy? Because white supremacy is by far the greatest public health threat to the entire planet. White supremacy is what gives us slavery. White supremacy is what gives us profit before people. White supremacy is what gives us the notion that we can deplete this earth and still be okay. Thank you.
And there's not much more for me to add to that. We are all here, I think all of us are here because we feel similarly strongly about injustices and about what we can do in terms of using our talents, our skills, our connections, our resources to help address the issue. So I thank you all for being here and for your time. I know we still have a few minutes left. Sorry, there's one more question. And I'm going to ask this. Anyone on the panel is free to take this. I'm also happy to comment on it if needed. How much of Hopkins' great research on health inequity makes its way into public policy and measurable improvements in the community?
That's a question for you.
Anybody on the panel? I'm happy to
Okay.
weigh into that as
You
well.
weigh first, and then I'll weigh second
Okay.
if need be.
So I think that's a fantastic question, and that's what so many of us here are working tirelessly on a daily basis. The issue is that, first of all, there's a lot of work to be done in actually documenting solutions to health inequity. So that's what we're working on. When we collect that information and when we show that something works, we still have the job of showing to people who pay for these things that this is something that they can afford to pay for. We have to really, and sometimes we're actually held to a higher standard than other scientists because our work is so socially charged and emotionally charged. So we actually are asked to show beyond a shadow of a doubt whether certain programs work or not and who actually benefits from them and what it costs to society to do that. So we have to do all of that. And then at the same time, we have to engage with policymakers and the people who actually do make these changes. Plus, there's a lot that we know about what works in a theoretical sense, but we don't really know what some of the issues are in the real world that might prevent people from being able to do what we know should be done. So, we couldn't go around saying, well, we found this new drug or we found this new program that works now, everybody needs to use it, but it might not be something that a federally qualified health center that doesn't have enough staff or doesn't have enough support might be able to do. So we really have to understand more about what those challenges are and work with those folks to identify solutions that actually are things that can be done and can be sustained over time. So, yes, we've contributed to a lot of positive research. In our own center, we've contributed to evidence that, certain treatments for hypertension and certain approaches, such as community health workers, are effective for controlling high blood pressure and reducing the complications of uncontrolled hypertension, like stroke and heart attacks. But now we have the challenge of actually showing the rest of the world that, it makes sense to pay community health workers. And we have to show them how to hire and train those people. So it takes a long time to do all of this. So this is an excellent question, and we need you. Whoever you are that submitted that question, join us.
I would add to that, and I would say, not quite. I think that that there is a shift that is occurring in our institution as well as in others that is also being imposed, for a lack of a better word, by our funding structures, that is requiring us to think more about the applications of the work that we do, of the research that we do, that we're trying to move the needle a bit more quickly, not less rigorously. Some of these questions, though, we know the answers to. And some of the questions, we don't need additional research. We need additional political will. We need leadership. We need people, stakeholders, and champions that will stand up and stand with us to say that, we are now ready for action. And so I think, again, we have the resources. I totally agree with what Dr. Cooper has said, that is not true for every bit of the work. We are still very much in the discovery phases of many things, but there are some parts of the work that we have engaged in where we've invested a lot of money and where we know the answers. It is now, where is the leadership? Where's the political will? Where is the professional will to really now take up some of these causes?
I just would like to make a brief comment about the some opportunities that the institution has and ways that it is making some connections. I would like for everybody to look up the Billie Holiday Project for Liberation Arts when you get out, or on your phone or on your computer. And please join us as we try to connect some of the resources, at least of the Homewood campus, to other parts of the city. We had a very successful event in Lafayette Square on September the 7th, where we hosted an outdoor jazz concert with the idea of contributing to public well-being in parts of Baltimore that are not touched by much of Johns Hopkins. We also have a number of other programs to share the intellectual resources of the university with other parts of the city. And I really could use your help and participation, especially those of you who like to measure the effects of arts on other parts of the city.
There are many who are unloving critics of Hopkins and some who are uncritical lovers. I'm a critical lover of my institution, that's my alma mater. And I think that we sometimes allow Hopkins to be taken off the hook. Hopkins is the 800-pound gorilla in Baltimore. When Hopkins speaks, Baltimore responds. And there are some ways in which Hopkins is speaking and Baltimore is responding. Hopkins has partnered with a part of our organization called Turnaround Tuesday to find livable wage employment for primarily for ex-offenders. And we've put, in the past 2 years, over 700 people to work in living wage jobs. Hopkins has partnered with us in helping to create funding for community health workers. A new venture that's employing people and also addressing some of the health needs in communities that are underserved. But again, being the 800-pound gorilla in Baltimore, Hopkins can and must do more in taking leadership. If the problems faced in Baltimore were any place else, Hopkins could solve them.
Thank you. We need you. We need those voices. We need your voices to be heard in all of our conversations. Final comment from Reverend Hickman.
And I would just like to add to what Bishop Miles just stated, because for the last 7 years, going on 8 years, Sisters Together and Reaching has been in direct partnership and direct funding from Johns Hopkins on training and hiring community health workers from the community, and they have been doing a stellar stand-up job, as well as we have been looking at working on opioid addiction and the like, and it is not just here in East Baltimore, but it is touching all across Baltimore City, addressing all of the social influencers that are in our community. And social influencers are just another term, or a better term, for social determinants. We should stop the people from saying social determinants, because it's already saying we're dead at the door anyway. But social influencers says that there is hope on every end of every situation, and that's what we are bringing to Baltimore. And I believe that through this and partnering and being at the tables with Johns Hopkins' finest, to their provosts, to their deans, presidents, and the like, hearts and minds are changing. So we need to also be careful of how we actually begin to strip people before we give them an opportunity to show their humanity, because the humanity that might have been before them is not the humanity that is now at the table with us having communion. So we should think, act, and be differently. And I also want to challenge us as Blacks. Black Lives Matter, as long as we understand that we can't take our own lives, that we must stand together, not apart. We must be like those in the Gullah Island that says that we're going to take good care of ourselves. We must be like those in Cuba that took care of themselves and are taking care and educating and making certain of good health in their communities. That's our charge. Nobody else is coming for us, so we come for ourselves, and we knock on doors and we demand and we wait and we pray and we get and we do. And that's what we need to continue to do, because this behemoth is greater than all of us. And if we take God out of the equation, then we're already dead at the door.
Come on, man.
Thank you so much. But could you join me in thanking our wonderful panelists?